In this video, I go straight to the point and explain why people develop ulcerative colitis and the evidence-based treatment. All the experimental and clinical data indicate that ulcerative colitis is caused by too much hydrogen peroxide being produced by the large intestine. The excess hydrogen peroxide is produced inside the cells that line the inner surface of the colon. When the hydrogen peroxide leaks out, it attracts white blood cells called neutrophils into the inner lining of the colon, leading to inflammation, abdominal pain, and ulcerative colitis. That's it. All cells in the body produce hydrogen peroxide. You don't have to take my word for it. This 2007 study confirmed that people with ulcerative colitis have significantly more hydrogen peroxide in their colons compared to healthy people. Right in the abstract, it states that people with ulcerative colitis have high levels of hydrogen peroxide in their colons. Furthermore, in the discussion section, the researchers concluded that excess colonic hydrogen peroxide can lead to ulcerative colitis. Radical induction is what I call this process leading to ulcerative colitis in my 2005 paper when I first proposed this new mechanism. I will leave the link to these publications in the description section below. So the next question is, why is your colon producing so much hydrogen peroxide in the first place? The answer is oxidative stress. Now I know what you're thinking. What is oxidative stress? Oxidative stress is anything the body is exposed to that causes excess production of hydrogen peroxide. There are a few oxidative stressors that are very common. One is a low-fiber, high-fat diet. This is your typical fast food diet. Another common oxidative stressor is stress, which can be psychological or physical. For example, young people leaving home for the first time to attend university can experience oxidative stress that can lead to ulcerative colitis. Alcohol is another very common oxidative stressor. Smoking cessation and drug use are also potent oxidative stressor. Lack of sleep can accompany many oxidative stressors. Also, there are usually more than one oxidative stressor present at any one time. For instance, stress, inadequate diet, alcohol, and lack of sleep seem to go hand in hand. When you add in a course of antibiotics for an infection and chemicals in food, it starts to add up. I have also added some additional oxidative stressors at the bottom. The mechanism of each is different. I will leave a link to my publication in which I explain the mechanisms of each of these oxidative stressors. Additionally, oxidative stressors have their own set of rules, and there are some important properties of oxidative stressors that people with ulcerative colitis should know about to prevent flares. Number one, a big source of confusion is because the effect of some oxidative stressors may be delayed. So, you may eat a double cheeseburger with fries and a milkshake today, but have a flare 2 or 3 days later after the food is completely digested and being metabolized. 2. Another very important property is that oxidative stressors are additive. This occurs because each oxidative stressor has a different mechanism that adds additional hydrogen peroxide to what already exists in the body. So you may be able to tolerate an occasional glass of wine, but if you are up all night in pain because of a toothache, a glass of wine the next day may cause a flare due to the additive effect of the stress of the pain and the lack of sleep. 3. Some oxidative stressors, such as chemicals in the blood, can be long-lasting. testing for chemicals in the blood may be indicated if you are having unexplained flares. 4. Oxidative stress is normal because every cell in the body produces hydrogen peroxide during cellular metabolism. If all potential oxidative stressors causing a flare are eliminated, then it's possible that the colon cannot detoxify the normal amount of hydrogen peroxide produced during normal cellular metabolism. In the past, these individuals were at high risk of having a colectomy. However, this can be effectively treated with reducing agents that prevent hydrogen peroxide from building up and causing a flare. An example of this is presented in the case report a little further on in the video. 5. Another property of oxidative stressors is that they can usually be identified and avoided. This is an important part of the treatment to prevent flares. 6. Also, it's important to note that oxidative stress affects every organ in the body. We see the effects in the colon first because of the inflammation and rectal bleeding, but other internal organs are affected as well in ways that are not so obvious. 7. The last important aspect of oxidative stress is that it's very individualized. Certain oxidative stressors may cause a flare in some people with ulcerative colitis, but not affect others. This is due to each person's unique lifestyle and genetic predisposition, which we will talk about next. Now, a little bit about genetic predisposition. So, what is genetic predisposition? Genetic predisposition is defined as an increased risk of developing a specific disease due to one's genetic makeup. For people with ulcerative colitis, the data indicate that this is caused by the inability to neutralize a hydrogen peroxide load in the colon, specifically in the cells that line the inner surface of the colon called the colonic epithelium. Our genes control how much hydrogen peroxide we can neutralize. If the production of hydrogen peroxide exceeds our ability to eliminate the hydrogen peroxide in the colon, the hydrogen peroxide will leak out, leading to ulcerative colitis. Genes control levels of everything needed to neutralize hydrogen peroxide, such as glutathione, enzymes, and certain antioxidant transcription factors required to neutralize hydrogen peroxide. Some people may have less of these factors or do not respond fast enough to rising levels of hydrogen peroxide in the colon, causing hydrogen peroxide to leak out, leading to ulcerative colitis. That's it. Despite nearly a century of research, there is no evidence for any autoimmunity, immune abnormality, or immune dysregulation in people with ulcerative colitis. If you have any doubt, you should send an email to anyone you think is an expert in inflammatory bowel disease and ask them to show you the evidence that ulcerative colitis is an incurable immune-mediated disease. And please send me a copy. My email will be in the comment section below. Although this may sound strange, the fact that you have ulcerative colitis means that you have a normal functioning immune system. Let me explain. Hydrogen peroxide is released by white blood cells called neutrophils at the site of infection and acts as a beacon to guide other neutrophils towards the infection. In ulcerative colitis, hydrogen peroxide is being inappropriately released by the colonic epithelium. Since neutrophils are programmed to migrate towards the source of hydrogen peroxide, they just go right into the colon. But there is no infection. Instead, it causes a colitis. The neutrophils are doing what they are normally programmed to do. The immune system is responding normally. So, what does this mean for treatment? Well, it means a lot. The data indicate that if you eliminate the excess hydrogen peroxide from the colon, the colitis will completely resolve. This is not only a treatment but represents a cure because people with ulcerative colitis don't have enough antioxidant capacity in their colons to neutralize the excess hydrogen peroxide. So when we provide the missing antioxidants to the colon, the hydrogen peroxide is neutralized and the colitis disappears. This was shown in a case report published in January of 2026 in a patient who had ulcerative colitis for 26 years. She failed to respond to all medications, including to biologics, and was advised to have her colon surgically removed by several gastroenterologists. She was treated with special antioxidants called reducing agents to neutralize the excess hydrogen peroxide in her colon. Within days, all bleeding stopped, and in a month, she was completely asymptomatic with normal bowel movements and, more importantly, a normal stool calprotectin level, indicating the complete absence of colitis. She continues well to this day, nearly 5 years later. I will leave the link to the case report in the comments section below. I encourage all gastroenterologists to read the case report as it describes in detail the rationale and the treatment of ulcerative colitis with reducing agents and the specific agents used. Additionally, the subject of the case report has graciously allowed her email to be published in case anyone would like to ask her any questions. I will leave her email address in the comments section below. The most important concept to keep in mind when treating ulcerative colitis is to realize that the inflammation causing the colitis is self-perpetuating. What does that mean? It means that white blood cells that enter the colon, called neutrophils, produce hydrogen peroxide that attracts more white blood cells, and so on. The colitis only stops when the hydrogen peroxide is neutralized. In other words, the oxidative stress that is causing the colitis are the neutrophils themselves in the colon. At this point, removing the oxidative stressors in your environment that you are exposed to will not stop the colitis. The only way to stop the colitis is to eliminate the excess hydrogen peroxide from the colon. So the next question is, how can you neutralize the hydrogen peroxide? In general, this can occur in one of three ways. The first way is that the colon itself does it. This is known as spontaneous remission. The scientific term for this effect is called oxidative conditioning hormesis. This occurs when the colon is exposed to oxidative stress caused by hydrogen peroxide. The colonic epithelial cells can upregulate their antioxidant capacity and neutralize the excess hydrogen peroxide. As you would expect, this does not happen very often, and it's not a reliable way to treat ulcerative colitis. The second way is to directly remove the hydrogen peroxide with reducing agents, which are the special antioxidants that neutralize hydrogen peroxide. Once the hydrogen peroxide is gone, the neutrophils stop entering the colon and the colitis resolves. And as long as the hydrogen peroxide does not leak out of the colonic epithelial cells, the colitis does not return. This is the method of treatment described in the case report. However, there is a third way. You can use immunosuppressive agents to prevent the white blood cells, called the neutrophils, from entering the colon. This will decrease hydrogen peroxide in the colon and temporarily resolve the colitis. This is not a long-term solution because the hydrogen peroxide is still leaking out from the colonic epithelium. So as soon as you stop the medication, the colitis will return. I discuss how to prevent this from happening a little further on in this video. Finally, Although removing oxidative stressors alone will not stop the colitis, it is very important to avoid oxidative stress because it will help the medication resolve the colitis, and avoiding oxidative stress will help prevent future flares. So, what are the goals of treatment? Number one is to eliminate the excess hydrogen peroxide with oral reducing agents. And number two, and equally important, is to identify and avoid those oxidative stressors that increase hydrogen peroxide in the colon. The case report listed in the comments section has details regarding the reducing agents used and the dose of each. Your healthcare provider must take the time to speak with you to identify those oxidative stressors that you are being exposed to so you can avoid them in the future. I discuss many common oxidative stressors in my previous publication, which I have listed in the comments section below. The treatment of ulcerative colitis is divided into two phases. The first phase is called induction of remission, during which the colitis is resolved, and the second phase is called maintenance of remission, whose aim is to prevent future flares. During the induction phase, oral sodium thiosulfate is used to neutralize the hydrogen peroxide that is causing the colitis. Once the hydrogen peroxide is gone, clinical remission should follow. Clinical remission is indicated by cessation of bleeding or diarrhea. Once clinical remission is achieved, transition to RDLA is indicated to neutralize colonic intracellular epithelial hydrogen peroxide and prevent future flares. I use the terms induction and maintenance because that is how ulcerative colitis is traditionally treated. However, the reason RDLA is effective in preventing flares is because it increases the colon's own natural ability to neutralize hydrogen peroxide. In this sense, it is a cure for ulcerative colitis. This is no different from the need to take daily vitamins. After 4 to 6 months, you can try discontinuing the RDLA. Some people may not need any more treatment, while others will need to continue treatment for a longer period. More details regarding dose and frequency can be found in the case report, whose link I've listed in the comments section below. In general, if you are in a flare, you must first use the STS to remove the excess hydrogen peroxide to achieve clinical remission, followed by the RDLA to prevent future flares, as outlined in the case report, whose link is in the comments section below. However, there may be occasions when this does not work. There are several important reasons why this might happen. I have listed some here. For instance, intestinal infection is a very common cause of flares, with up to 30% of flares caused by intestinal infections according to some sources. In this case, you need to do a stool PCR test for the many possible types of bacteria that can cause infection. I go into testing in more detail on the next slide. Stress of any kind is another oxidative stressor that can cause colonic spasm, which increases colonic hydrogen peroxide that can lead to a flare. Straining when you are constipated is a significant oxidative stressor that can trigger a flare. Inflammation due to diverticulitis or other localized conditions such as colonic ulcers can trigger a flare. Diet and lifestyle are perhaps the most common oxidative stressors. We already mentioned those in a previous slide. Certain vitamins, such as the form of vitamin B6 called pyridoxine, generates hydrogen peroxide and can trigger a flare. People with ulcerative colitis should use pyridoxal, which does not generate hydrogen peroxide. Comorbidities, which are other medical conditions outside the colon, can be significant oxidative stressors that lead to a flare. These can be in direct contact with the colon, such as endometriosis or pelvic inflammatory disease, or indirectly from a viral illness. Nutrient deficiencies in protein or certain vitamins and minerals can decrease your antioxidant levels and trigger a flare. Chemicals in the blood from food or tap water can be significant oxidative stressors that can trigger a flare. Lack of sleep and sleep apnea are significant oxidative stressors which can contribute to a flare. Other less obvious conditions such as intestinal ischemia can generate hydrogen peroxide due to a perfusion-reperfusion injury in the colon and trigger a flare. The treatment of ulcerative colitis hasn't changed conceptually since the 1950s. When someone is diagnosed with ulcerative colitis, they are usually prescribed a course of tapering steroids and a medication called mesalamine. When these stop working, patients are prescribed powerful immunosuppressive drugs, such as biologics or JAK inhibitors. And when these stop working, the only option is surgery. These medicines don't cure. They just suppress your immune system and mask the symptoms. And it's dangerous to remain immunosuppressed your entire life. And most patients with ulcerative colitis will stop responding to these drugs because they do not address the underlying cause. The only safe long-term solution is to address the underlying cause of the condition. The only difference between today and the 1950s is more creative surgical procedures and more expensive and profitable immunosuppressive drugs. So you can see that there's something wrong here. So what is the problem? Number one, none of these drugs address the underlying cause. If you don't address the underlying cause of a disease, which is excess hydrogen peroxide in the case of ulcerative colitis, you will never be cured. 2. Hydrogen peroxide continues to build up in the colon while taking these drugs. The leaking of hydrogen peroxide contributes to inflammation, which increases the risk of colon cancer or surgery. It also contributes to you becoming non-responsive to one immunosuppressive drug after another. And 3, there is always a reason for why you developed ulcerative colitis or a flare. It's up to your doctor to take a complete redux history and perform a physical exam, in addition to ordering the appropriate tests to identify the oxidative stressors that caused your ulcerative colitis. This is the only way to achieve long-lasting remission. Prescribing drugs that don't cure and then sending you right back to the same environment that caused your disease in the first place will lead to failure and a colectomy in many patients. This is not rocket science. In conclusion, for as long as research has been ongoing to uncover the cause of ulcerative colitis, no pathological organism or pre-existing immune abnormality has ever been discovered to account for the development of this condition. This has led to a default explanation of a so-called immune dysregulation as a means to impart a sense of conceptual progress towards identifying the cause of this disease. Just what is meant by immune dysregulation is not clear, so it's really a meaningless concept backed up by no evidence. In contrast, there is hard experimental and clinical evidence that ulcerative colitis is caused by excess colonic epithelial hydrogen peroxide. Given the potential significance of this new mechanism, there is an urgent need for rigorous, independent evaluation of both the underlying redox biology and the associated therapeutic approach with reducing agents that neutralize hydrogen peroxide in the colon. Such investigation is essential if we are to move beyond the current treatment paradigm, which relies on trial and error use of immunosuppressive agents until surgery becomes necessary for many. In other words, the current treatment of ulcerative colitis is effectively a guessing game, an approach that places a heavy burden on patients and clinicians alike. A validated mechanistic approach can open the door to more targeted, effective, less toxic, and potentially curable treatment strategies. And lastly, given the urgent need to find cures for the millions of individuals living with ulcerative colitis and Crohn's disease, the Crohn's Colitis Foundation should consider establishing a major incentive prize for the discovery of the cause or cure for either condition. Each year, the foundation raises tens of millions of dollars from patients and families with the stated mission of identifying the underlying causes and ultimately curing these diseases. Yet, it has never offered a financial award specifically designed to accelerate breakthrough discoveries. A prize of $10 million would create a powerful global incentive, attracting top researchers, innovators, and scientific teams to focus their efforts on these conditions. Strategic incentive funding of this kind has a proven track record of catalyzing rapid progress in other fields. Implementing such a prize could represent one of the most effective and efficient pathways towards achieving a cure. You can email the CEO of the Crohn's Colitis Foundation at this email address and request that they offer a cash prize for discovering the cause or cure for these diseases. This will get scientists from around the world working on the problem. On behalf of everyone with ulcerative colitis and Crohn's disease, I hope they listen. Thank you for watching.